Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello. We're going today to talk about immunology and MDS. And I'm Kirsten Gronbaek. I'm a professor of hematology at Rigshospitalet at University of Copenhagen in Denmark. And I'm seeing MDS patients in the clinics, and I have a lab where we also work with MDS. And today, it's my privilege to welcome Shahram Kordasti. He is an associate professor and a group leader in applied cancer immunopathology at King's College in London, and honorary clinical hematologist at Guy's Hospital in London. And Shahram has been working with immunology and MDS for many years, and he also has been working a lot with multidimensional cytometry. So welcome, Shahram. We're looking forward to hear your thoughts about MDS.
Thank you. Thanks, Kirsten, for invitation and for the nice introduction. So today we're going to talk about immunology of MDS, and as you mentioned, and see what we know and what we don't know. Perhaps what we don't know is more than what we know. Despite several years of working, we know much more than what we used to, at least, and that's a good news.
Yeah, so I think now, we've learned all these things about the mutations over the last 10 years and how important they are, and that they start at an early time point. And so what is does immunology really play a role, and what's the hen and the egg in this situation? Can you elaborate a little bit on that, maybe?
Yeah, we get this question a lot, and you're absolutely right. I think we made a huge progress in terms of understanding the pathophysiology of MDS, and especially with this IPSSM and generally more standardized way of looking at mutation. We have a better understanding of the events that are happening in MDS. That's excellent, but I think that's not the whole story for several reasons. Of course, there is no one reason, and this is a complex disease, a group of diseases, I have to say, considering the new classification. Really, we need to say that we are not talking about one disease. We're talking about a complex, several different conditions at least, and each of them, they have different interaction with the immune system. So there are general evidence that, for instance, the Karolinska study that published a few years ago, they look at a huge number of MDS and AML, and they've shown that presence of autoimmunity or chronic inflammation due to infection, for instance, increase the risk of MDS and AML. So in the pathophysiologic level, and in epidemiologic study, you can see that. Other than that, we and others, we have shown that both the innate immunity, myeloid-derived inflammation, as well as adaptive immune response are important. They correlate with risk of disease progression. And in the pathophysiologic level, with a specific mutation, you can see that they play a part. So
can I ask one thing here? Because what about this inflammation you see? Is that produced by the mutated cells, or is it already there? What do you think about that?
Very good question, and not easy to answer. I think there are, if you look at my first slide, which basically summarizes the MDS pathophysiology, we have environmental factor, genetic and age itself play an important role. Inflammaging, what we call, play a role. Presence of some genomic background may play a role. But somatic mutations, we have different groups of mutations. There are mutations that they contribute to the inflammation, and some of them, they are less important, and some of them contribute to immunosuppression, for instance, like TP53. So we cannot give a general overview and say each mutation, all mutations, they play same role and they contribute or not contribute to the inflammation. Some of them they do, some are less likely.
Yeah. Can you mention some of those that do contribute to inflammation, just for our understanding?
So, for instance, there are a few that are less know about, like ASXL1 or SF3B1, but ASXL1 is more likely to contribute? That's a very good question, and obviously not all the somatic mutations, they play the same contribution or not contribute. It's not one simple clause that we say, okay, this they do or not. But some of the mutation, like U2AF1, it's been shown that they contribute in the pyroptosis and inflammation, and some are less important, or at least they are suggestion, although they are some controversial data, but that like SF3B1 that are less contributing to the inflammation. And some of them, not only not much related to inflammation, they contribute to the immunosuppression, and TP53, for instance, been shown to expand regulatory T cells and contribute to immunosuppression. So somatic mutations, they have different roles, depends on which class of mutations they are coming from. And some of them we don't know yet.
But what about, I think also TED2, there's been a lot, at least about, they have this mouse model and stuff, right?
That's correct. That's correct. Yeah. Exactly. So I'm not going to name all of them. We are talking about 40.
I agree. I'm thinking of
and some of them we don't know, some we know, some of them. So it's still ongoing, but at least a few very important ones, we know that they contribute differently. Some they do, some they don't, and they have different roles. So this, what we call basically inflammation and myeloid-derived inflammation, is an important pathophysiological aspect of MDS. And that's the next slide that I've shown, that NLRP3 pathway activation, pyroptosis, and a vicious circle of cell death and contribution to inflammation.
So if inflammation is so important, why doesn't something like prednisone work in MDS, or does it?
Yeah, it's a very good question. So first of all, this inflammation, it's when we talk about immune dysregulation, we're talking about a multifactorial immune response. And if you look at my next slide, the inflammation has short effect and longer term effect. And in short term effect, so in short term, so at the very acute phase, we need the inflammation because it's awakening the immune response in infection, in cancer, for cell death. So that is what we call the acute phase inflammation, and it happens to all of us and is always there. Cancer also at earlier stage present. And those are the inflammation, they respond very well if you want to subside. Whether it's good or bad is a different story, but they respond. But the inflammation level can go down, and what we call it a smoldering inflammation. This smoldering inflammation is in the background. It's has genotoxicity, it contributes and change the immune environment to immunosuppressive environment. This immunosuppressive environment is an environment that doesn't respond to classical immunosuppression techniques that we use. For instance, giving a steroid doesn't help in that environment. You already have a immune suppressed environment. Unfortunately, this inflammation is more harmful one, and it's a smoldering that drive the genotoxicity and drive the malignant clone. And controlling is not that straightforward. You need to be more specific.
Yeah,
those are the targets.
So the specific cells that expand in that situation. Can you?
Yeah, MDSCs, exactly. MDSCs can expand, Tregs expand. Exhaustion of T cell will happen on that environment. And these are basically the cornerstone of that immunosuppression. NK cells become less effective in terms of their function. And so it's not just MDS. Remember, this happens in most cancers. And as I show in the next slide, we have a stepwise from active immune response to more immunosuppressive environment and immune escape. And this immune escape happens in all cancer. MDS is not an exception.
I always found it very difficult to understand this switch, we have in low-grade MDS to high-grade MDS. I mean, what's driving that, do you think?
Yeah, I think at that stage, I think the other aspects like genetic become more important. I think initiation, as you know, not at least as far as we know, not all high-risk MDS coming from low risk necessarily.
No.
So depends on what genetic factor involved, etc. And not all low-risk MDS go to high-risk, or all high-risk MDS go to AML. So, of course, majority of them go on high risk. But what I'm trying to say is not necessarily a stepwise that we see in every single patient. So there are other factors involved. What mutations are exist? What environmental factor involved? All the rest are also important. So it's not just one factor. But from immunological point of view, definitely there is a switch of more of the inflammatory, maybe T cell response. And you can see that some low risk MDS, they respond to ATG, for instance, which you don't expect in a malignant disease to respond to ATG. So it means that at that stage, we are talking about different. And basically, that brings me to the next slide, that basically to think about the immune therapy. Perhaps you want to ask, okay, if it's the case.
Yeah, why doesn't it work then? Or does it work?
Yes, it's a good question, because when we talk about this immune response in MDS, the first question they ask, we give checkpoint inhibitor, it doesn't work in MDS. I need to remind ourselves as hematologists that we are the first that we actually did immunotherapy in human, and we should be very proud of it. And that's stem cell transplants and giving the life. These are immunotherapy and cell therapy, and very successful one. And that's the
and the only one that can cure patients. We should remember,
exactly,
right?
the only curative option.
Yeah.
And therefore, as you can see in my next slide, we have a group of patients, a lot of them, that they benefit from this type of immunotherapy. We should remember bone marrow transplant is inducing the immune response against leukemic clone, and that is an immunotherapy. Awakening the immune response is a very important thing, and we already doing it. So yes, we do immunotherapy in MDS, and actually that's the only curative option. But not for all patients, for several reasons. They don't have donor, they are not fit for transplant, etc., etc. The other option, as I mentioned, is the other group that some of them, they need immunosuppression, which is a bit strange. You need to give ATG or immunomodulatory lenalidomide, which again feels like, okay, so what we are talking.
But that was more the low risk, right? We're talking about now, right?
Exactly.
Yeah. So where you still have a very active immune system in a way.
Exactly.
Yeah.
But even 5-ASA, hypomethylating agent. Remember, hypomethylating agent is not an immunomodulatory, but it has immunomodulatory effect.
Yeah, because it does upregulate some things that could be. Yeah.
So there are other factors. And therefore, if you look at my next slide, what I try to visualize here, that when we talk about immune dysregulation, we're talking about a spectrum between inflammatory or autoinflammatory diseases to autoimmune diseases. Autoimmune disease like IPEX is autoimmune disease, T-cell related, is nothing to do with inflammation as such. Or when we go to Sweet syndrome.
So it's the innate versus the adaptive immune system. Yeah.
VEXAS is very much inflammatory and not much T-cell response as such. MDS sitting in the middle. And in the middle, it means that it has elements of T-cell response and autoimmunity and elements of inflammation. Some patients are closer to the autoimmune side, some patients closer to the autoinflammatory side. Those patients with Sweet, for instance, or those patients with hypoplastic MDS, not all of them, some of the hypoplastic MDS perhaps are closer to the AA side, similar to AA.
And we don't really, I mean, it's not really used in the new classification, all this, is it? Or,
No, not really. And that's
no.
something I think is missing.
Yeah, I think so too, because how should we then figure out how to choose the treatment?
Yes, exactly. And if I revisit the question of treatment, my next slide shows that, yes, checkpoint inhibitors are not very promising, but a few percentage of patients, they respond. But what are they? Who are they? Do we have any criteria to predict who will respond? And then the next slide, I'm showing an array of immunotherapy methods that almost all of them are being used now in MDS clinical trial. My worry is, and that's a worry that makes me a bit nervous, because I'm worried that if we choose our patients for this trial based on IPSS, IPSS-M, IPSS-R, whatever we do, and based on that, is nothing to do with the immune system. No. And therefore, we choose this patient and we give them immunotherapy methods.
Like,
exactly, we are choosing patients not suitable, and therefore at the end we may get 5% response, 10% response, and not very.
Yeah, but there's a small group, right? So we have
exactly.
to. Yeah.
So we need to identify them, and I think that is a very important and kind of crucial point that we need to highlight. That it is important that in these patients we need a better approach and include other factors. Somatic mutations are absolutely important, vital. Whatever included in IPSS, they are shown to be important for the, and it's validated by several groups for the survival. But here we are not talking about survival, we're talking about prediction. And I don't think IPSS-M even is good enough for predicting response to therapy.
No. It's not validated for that either, is it? I mean, that was not even the
that was not the reason.
No.
So the next step, I think, is we need an additional approach, and to have a combination of clinical data, somatic mutation, different omics study to look at immuno, genome, microbiome, combination of all of these, scale them, and then have another classification that it's designed for response to therapy, which we don't have at the moment. And
this is very interesting, Shahram, but how should we do that in a general hospital? It sounds like a complicated procedure. So how would clinicians?
Yes, I think this is not something that we should expect a general hospital or a hematologist in general hospital to. I think we need a collaborative study in big centers.
Yeah.
With, as we did for the somatic mutation, it was several centers contributed and analyzed sophisticated method, go down to a list of genes that can be tested, then in general hospital, in routine basis, and then can be used. I think the same needs to apply here. Needs to be done sophisticated with omics study, etc., but not on day-to-day basis. We need one big study to do this, and at the end of it, we say, okay, these are the factors that needs to be tested in routine lab. Which could
or maybe you can make an algorithm or something like that.
Exactly,
right?
An algorithm based on that, and then come up with, okay, for each patient, a few simple tests for inflammation and immune response, for instance, needs to be tested. And once this done, this is the algorithm. Okay, this kind of group of patients, they are more inflammatory. So
we go for
give them IRAC inhibitor, TLR4 inhibitor, or something around that line. These patients are very immunogenic. It seems like they may have T-cell response. Maybe they benefit from ATG, which we don't do much these days, for instance.
No, that's true.
These other patients, well, they are not really immunogenic. It seems like we should go for transplant or something on that line.
What about vaccinations, Shahram? Do you believe in that?
Yeah, exactly. There are, as you know, there are studies at the moment that try to do the cell therapy based on neoantigens that to do. I think we are early days. One aspect that we shouldn't forget is the most, we are talking about, we are not a confined tumor like solid tumors, that malignant cells are not exposed to immune system. We are talking about an open malignancy. So all the cells are already exposed to immune system.
Yeah.
And the most immunogenic clones were already eradicated. So the remaining one they have to be less immunogenic, otherwise they would have been eradicated. So to reinstate immune response, or they manage to suppress immune response in a way to not to recognize basically them. To overcome that, it's a bit more challenging, and we need to focus on unusual kind of antigens. For instance, spliced neoepitopes that in in solid tumors, for instance, in melanoma, even shown that it's a group of neoantigens that are less known, but a paper published in Science by Michele Misto's group, they have shown that they can induce immune response, and if you do vaccination, you get a good response. But because they are not very well known and they are not that frequent,
they're not expressed by other cells also.
Exactly,
it's very important, I guess.
So that's why I think we need to a more precise approach on that. But I believe vaccination has its own, and also you know that for instance in Amsterdam,
Van der Loosdrecht
is doing a vaccination with dendritic cells, which is also very encouraging results. So yes, I think the vaccination is also on a specific patients has a role.
Yeah. Okay. Good. So I think we came very far around this very, very interesting subject, and I think we could talk about this for 2 more hours without maybe finding the right treatment still, but I think this is really worth working on. Yes, so I would like to thank you very much, Shahram, for giving this opportunity to hear your thoughts.
Thank you very much for inviting me, and I hope it's useful for the members of EHAT that they want to know more, and hopefully we will hear more and more about these subjects in years to come.